Hello, Troy Family Medicine residents. Thank you for finding and tuning into this presentation on fetal assessment. So as you might have heard, we had some trouble trying to record this in the classroom. So unfortunately, you guys weren't able to attend the live presentation, but I'll do my best to replicate it. So unfortunately, you guys don't have the advantage of really seeing the questions that came up then, but I'll try to incorporate those into this presentation. And also I've gotten some copies of the exam back and had a chance to grade them. So I'll try to incorporate some material that people have had some trouble with. So just to recap the requirements for you guys, all first-year residents and all OB track residents will need to obtain their certificate of added qualifications in fetal monitoring from the NCC. I'll give you guys more information on that a little bit down the road when we've cleared things up, like budget for taking the test. For the third-year residents and second-year residents who are not on the obstetric track, you guys just need to pass your paper exam. You need to score at least an 80% on it. So if you were at the Third Thursday workshop, you should have received a copy of the exam at that time. If you were not there, I do have one in your mailboxes. Once you're done with it, please turn it in to me. I'll correct it. I'll go through and I'll give you some feedback on any questions that you got wrong. And go from there. So my hope is that for those who are taking the NCC exam, that'll help provide some good rounding out of your knowledge on fetal assessment. And I really hope that this lecture does more than just gets you ready for the exam. I think it should really help you in accurately interpreting fetal monitoring, putting it all into context, and really knowing what you're talking about over on the labor and delivery floor. So without further ado, let's get into the presentation. So objectives for this lecture is that by the end of it, I want you to really understand the basic physiologic principles that underlie fetal monitoring. And just to warn you, the NCC exam, at least when we took it the first time back in 2013, the NCC exam was pretty heavy on underlying physiology, probably more than you've really practiced or learned about on your OB rotation up to this point. If you've taken the ALSO course previously, I think you have a good knowledge of what to do with how to assess fetal monitoring strips, but this gets a little bit deeper into the underlying physiology behind it. However, I do think if you understand the physiology well, it'll help you get a complete picture and make sense of electronic fetal monitoring. I want you guys to be able to state the indications for fetal monitoring, and then, and with that, have some knowledge of use of structured intermittent auscultation versus continuous electronic fetal monitoring. I want you guys to get comfortable with defining fetal heart rate patterns in accordance with the NICHD guidelines, and they're using their terminology. So this is, of course, categorizing fetal monitoring strips as category 1, 2, or 3, and explaining the implications for further monitoring from that. Rather than saying that the strip looks good or bad or just reassuring or non-reassuring. I want you guys to be able to describe normal and abnormal uterine activity and know its significance, and then discuss how and when different intrauterine resuscitation measures should be undertaken. All right, next slide. So a little bit of background on the history of electronic fetal monitoring. It was introduced in the 1960s, and we thought that we could really reduce the incidence of cerebral palsy. And as our lawyer friend from Scrubs here pictured points out, well, unfortunately it didn't. And reasons why are a little bit complex. So most cerebral palsy is due to events occurring outside of the intrapartum period. And fetal monitoring strips have a very poor specificity for a bad outcome. I'm sure you guys have all probably seen a really ugly looking monitoring strip, recurrent variable decels, some late decelerations. Oftentimes they look really bad during stage 2 of labor when your patient is pushing. Then the baby comes out looking just fine with APGARs of 9 and 9 and perfectly good blood gases. So they have very poor specificity, so it's really hard to use them to prevent actual cases of cerebral palsy. They haven't really lived up to their billing for doing that. All right, so basics. So the first line on this slide is one of the most important, probably the most important underlying principle about fetal heart rate monitoring that I want you to know and have in the back of your head whenever you're doing heart rate monitoring interpretation, be it on the exam or on the floor. And that's that the fetal heart rate strip is essentially just a surrogate a non-invasive means of estimating fetal acid-base status. We can't go and easily do a arterial or capillary blood gas on a fetus, and we use the heart rate monitoring data as a surrogate for that to tell us more about acid-base status. There are two primary methods of how to do this. There is structured intermittent auscultation or continuous electronic fetal monitoring. Now, continuous electronic fetal monitoring is going to be the primary thing we talk about today, and it's going to be the primary method of monitoring that you see on the labor and delivery floors at both Troy and Royal Oak. Structured intermittent auscultation, I want to just talk briefly on what that is in case you're working at a different hospital in the future, or maybe you're doing some work with one of the midwives in one of our natural birth rooms. You may come across this. So this is basically monitoring the fetus through intermittent use of the fetal Doppler. The Dopplers are just the same as what we have in the office. They may be monitored every 15 or 30 minutes depending on the stage of labor, and then contractions are felt by palpation. So you need really well-trained nurses who are comfortable with this for monitoring babies. That monitoring by palpation, they're really just kind of feeling for contraction intensity and frequency. So you've probably seen this just on the floor when you're trying to determine if the tokometer is graphing contractions right. You can kind of feel when a contraction is occurring. Best felt by kind of palming the abdomen and feeling for contraction strength with your fingertips. And then calculating the timing of how often those contractions are occurring. So this is commonly done in many hospitals in low-risk women as the primary method of auscultation. Where I trained, we really commonly did this with our term natural labors. Continuous electronic fetal monitoring is what's most widely used now and used for the overwhelming majority of patients at our hospital. And then know that interpretation of continuous electronic fetal monitoring strips really need to take into account a lot more than just what you see on the screen. Right? So you have to think about prenatal risk factors, think about intrapartum risk factors, like are we giving Pitocin? Does the patient have an epidural? Have I given a pain medicine? Think of the concept of fetal reserve. So a monitoring strip that looked great throughout the last 3-4 hours of labor and then now gets a little bit rocky later in labor, you're going to interpret that in a little bit of a different context than a monitoring strip that's had recurrent late decels throughout and now is looking worse. Also, interpret electronic fetal monitoring in the context of labor progress. So if you're having ugly looking decelerations showing up remote from active labor, that has different implications than getting some variable decels, in stage 2 of labor when a patient is pushing. All right, next slides. So hopefully this doesn't give you nightmares or flashbacks from embryology in your M2 year, but you do need to be familiar with fetal circulation and how it works. So I'm going to kind of walk you through it here, okay? So the structure of veins and arteries in the fetus is just the same as it is in us, right? So arteries do have a smooth muscle wall, veins are floppy. So, but the kind of the function in the umbilical vessels is different. Here, the vein is carrying the oxygenated blood and the arteries are carrying deoxygenated blood. So the umbilical vein starts up within the placenta. It kind of drains oxygenated blood from the intervillous spaces of the placenta, carries it up to the liver, where most of it is then shunted through the ductus venosus into the inferior vena cava. From the inferior vena cava, oxygenated blood travels into the right atrium of the fetus, where most of it is preferentially shunted through the foramen ovale and into the left atrium. Some of it does drop into the right ventricle, and from the right ventricle, it is pumped partially into the lungs and partially through the ductus arteriosus and into systemic circulation. Blood that goes through the foramen ovale and into the left ventricle, that is all sent towards the fetus's systemic circulation. So you see the blood then course through the aorta, go everywhere where it needs to go, to the brain, the kidneys, all the essential fetal organs. And then blood that gets down towards the iliac vessels. Some of it from there goes back into the umbilical artery, which carries deoxygenated blood back to the placenta. So I apologize, you do need to actually know this stuff. So take a good look at this slide and try to commit the functions of the umbilical vein, ductus venosus, umbilical arteries. Try to commit those things to memory. All right, a little bit more about fetal circulation on the next slide. So fetal blood has about 50% more hemoglobin than maternal. So, if you've gotten a CBC on a baby, you're seeing hemoglobin levels of around 20, 22 pretty commonly, where maternal hemoglobin at around time of delivery is usually low, 10, 11, 12. And fetal hemoglobin carries about 20 to 30% more oxygen than adult fetal hemoglobin. Oxygen is preferentially delivered to the heart and to the brain. I showed you those shunts on the previous slide. Baby doesn't need to use the lungs for very much while in the womb, and blood is shunted away from the right side of the heart. We know that kind of flips on at time of delivery, and those shunts start to close off. So this shunting away from non-critical organs gets more pronounced if the fetus is compromised in any way. If oxygen delivery is compromised, the fetus is going to decrease perfusion to kidneys, to lungs, to non-essential organs, and really try to shunt it towards the heart and brain. Where we can see this objectively in our testing is decrease in amniotic fluid. So oligohydramnios is oftentimes an early sign of a decrease in renal perfusion caused by a decrease in oxygen and nutrition delivery from the placenta. All right, more physiology that you need to know. I think this photo is blocking some of the slide, and I'm going to try to make it go away. Ah, darn it. Anyways, I'll explain it. So fetal autonomic nervous system, you do need to know this. So heart rate is really determined in the cardioregulatory center in the fetal medulla oblongata. That's what integrates input from fetal baroreceptors, chemoreceptors, and circulating hormones to affect fetal heart rate. So parasympathetic tone gradually increases with fetal age. So you can, kind of conceptualize this from what you've seen in prenatal visits. When you first hear the fetal heartbeat at around 10, 11, 12 weeks of age, usually when you find it, it's in the 160s, even 170s early on. And as the baby grows, that heart rate does gradually decrease. Normally I tell patients that throughout most of pregnancy, a heart rate between 120 and 160 is normal. In a baby that's 39, 40 weeks post dates, you can see that average heart rate dropped as low as the 1-teens. Now the parasympathetic system is stimulated by head compression, by vaginal exams. It can be stimulated by repeated scalp stim. Note that's different from initial scalp stim. Then anything else that squeezes on the baby's head, like forceps or vacuum application. These cause decelerations in heart rate via parasympathetic nerve output. Now, the sympathetic nervous system stimulates pericardial nerve fibers. So heart rate gets increased by the release of norepinephrine and pericardial nerve fibers. And these can be stimulated by maternal anxiety, fear, pain. These are stimulated by initial scalp stimulation, and also things like vibroacoustic stimulation, palpation of the maternal abdomen, etc. All right, next, specifics on how the baroreceptors work. So baroreceptors in a fetus work just like a baroreceptor in adults. So as blood pressure increases, they signal to decrease heart rate in response. These are located in the fetal aorta and in carotid vessels, and this is a very rapid working system. So as blood pressure goes up, it causes an abrupt change in fetal heart rate. So this is what you're seeing in variable decelerations. Abrupt response, variable deceleration occurs. On the flip side, when blood pressure decreases, so like poor maternal hydration, and blood pressure decreases, the sympathetic nervous system will cause an increase in fetal heart rate. Chemoreceptors. Now this takes a little bit more to conceptualize. So chemoreceptors are stimulated by an increase in carbon dioxide or by a decrease in oxygen. What happens is this stimulus causes a release of fetal catecholamines, and then fetal catecholamines cause an increase in blood pressure, which then stimulates baroreceptors to decrease heart rate. So a chemoreceptor response is slower. This is what you're seeing in a late deceleration. So uteroplacental insufficiency is going to cause either an increase in carbon dioxide in the fetal bloodstream, a decrease in oxygen, or both, which is going to increase catecholamine release, which will then increase blood pressure and then cause a baroreceptor response. So multiple steps in the process. It's a slow process. Chemoreceptor stimulation leads to late decelerations. Now that's going to often be your first sign of it. As pH drops over time and CO2 increases, you may also see a rise in fetal heart rate baseline. So a real worrisome sign of placental insufficiency would be late decelerations coupled with a rise in fetal heart rate baseline. So a stressed fetus, we'll just take a minute to try to conceptualize this and what's going on in the uteroplacental unit once it's under stress. So more functioning placenta is good, right? You have more oxygen delivery, more energy delivery available to baby. Less functioning placenta is bad. Things that chronically impair the placenta include things like tobacco use, chronic hypertension, gestational hypertension as well. Abruption, you can have a partial or chronic abruption that's detaching portions of the placenta and making it no longer exchange oxygen and CO2. Diabetes, particularly type 2 diabetes, can impair placental function, and there you've got a combination of maybe a larger baby with larger oxygen demand, greater metabolic requirements, and less functioning placenta. So all these things can decrease the functional size and area of the placenta. And you can really have up to a 50% decrease in the functional area of the placenta before any type of acidosis develops. And this can be going on undetected when, sorry, that's a pager. This can be going on undetected until you add a stress to the situation, like labor. So contractions raise resistance in the placenta and decrease perfusion further. Less functioning placenta means less placental reserve. Think of the placental reserve as how much oxygen is available to the fetus during a contraction, during a time when the fetus is more stressed. So if you take a poorly functioning placenta, throw in the stress of labor, you're more likely to have a further stressed fetus. All right, so fetal response to stress. This baby in the upper right-hand corner looks really stressed out. Maybe mom's hypertensive, maybe she's smoking, maybe she's in labor, maybe all three of the above. So fetal response, you have a chemoreceptor response to increased CO2 or decreased oxygenation or both, causing then baroreceptor stimulation and fetal decelerations. That chemoreceptor response also, you have more circulating catecholamines. That's going to redistribute blood flow to the heart, brain, and adrenals and spare less essential organs like the kidneys. So that's why you see oligohydramnios in a more stressed fetus. The areas that aren't getting adequate blood flow, they're going to rely on anaerobic metabolism. That's going to produce lactic acid and lead eventually to metabolic acidosis. We try to detect these things further up the chain than metabolic acidosis. We'll get into more on that in antepartum testing towards the end of this lecture. All right, maternal conditions, how these affect placental function. So I've mostly touched on this, but just to review, hypertension causes vasoconstriction in the placenta. Decreased placental perfusion can lead to growth restriction. If you've ever delivered a patient with like chronic hypertension or preeclampsia and taken a good look at the placenta, you can actually see small placental infarcts and calcifications, and those are evidence of areas of the placenta that are not functioning well. So diabetes, likewise, you get greater metabolic demand on the placenta, and especially in type 2 diabetics, you can see a reduction in uteroplacental perfusion. And then maternal hypotension, usually this is occurring all of a sudden, supine positioning impinging on the inferior vena cava, or epidural placement causing a decrease in blood pressure. You can get sudden decreased flow through the placenta. All right, so we're going to move on from here to actual monitoring. So again, remember back to that objective slide where I told you that continuous electronic fetal monitoring is essentially a surrogate for fetal acid base status. So also, you cannot view it in a vacuum. You cannot view a fetal monitoring strip as just what's going on in these 10 minutes on the monitor. You've got to view it in the context of maternal comorbidities, got to view it in the context of potential fetal comorbidities, look at what is the uterine environment like, is the contraction pattern appropriate, or is she contracting too much? Is it tachysystole? And then also look at labor progress and how close are you to delivery. So you really need to have a structured approach. So if you've got a pen and paper, please write down this next mnemonic, Dr. C. Bravado. So this is going to help guide you through fetal monitoring interpretation. And as we review some strips at the end of the presentation, this is the structured approach that I want you to have as you do that here and in real life on the floor. So Dr. C. Bravado is first determine risk. Is this, and there's not like one way to do it, but I really try to think of this, is this a really low risk situation, a high risk situation, or is it something in between? Look at contractions, and contractions you're going to define as a normal uterine environment or tachysystole. The BRA in Bravado is baseline rate, then heart rate variability, accels, decels, and your overall assessment, which you're going to break down into category 1, 2, or 3. All right, so first part, determining risk. So here you're looking at the prenatal risk factors and the intrapartum risk factors. So prenatal risk factors, this is your diabetes, hypertension, obesity, and I've got Dr. House right up here in the corner saying it's not lupus, it's never lupus, and well, that's generally going to be true, but there's one little important thing to think about that you may be asked about, and that's just good to know, and that's what's the thing that lupus can do to a heart rate that basically no other disease does. If you remember back to medical school, you might have remembered that lupus can cause congenital heart block. And this is in patients with specific antibodies. I think it's like the anti-Ro and anti-La antibodies, one or the other. It can cause fetal heart block, and you can see fetal heart rates as low as the 50s or 60s as a result. So that's the one time in fetal monitoring where the answer might be lupus. But other than that, hopefully you don't see that. Intrapartum risk factors include things like, what are we doing to mom? Are we giving Pitocin? Are we giving magnesium? Did we just give an opiate? So that's how you're going to kind of determine intrapartum risk there. Look at those kind of factors. You're looking also at labor progression. You're going to view poor labor progress differently from good labor progress. And then think of this concept again of fetal reserve in determining risk. So when you're interpreting a fetal heart rate strip, think about it in the context of what did it look like earlier? Have we had concerns for uteroplacental insufficiency throughout the labor, or did it just get bad all of a sudden? Maybe it's something that's temporary and very reversible. All right, next in your mnemonic is C for contractions. So most of the time, we're measuring these with an external transducer, and key point here about external transducers is that they do not measure strength of the contraction at all. It's tempting to think that they do. Sometimes we'll see the transducer make big waves on the contraction part of the strip. Sometimes we'll see it make little tiny contractions. This has more to do with location of it and patient's body habitus than it does actual strength of the contractions. Now, an IUPC is your one reliable way of accurately monitoring the strength of the contractions. That's going to measure the pressure inside of the uterus. And then direct palpation with your hand on the uterus, or hand on the maternal abdomen, can give you a sense of how strong the contraction feels. If you go and look through nursing notes, you'll often see this described as mild, moderate, or strong based upon their palpation. But the external transducer, again, key point, does not measure strength of contractions. Just says, is contraction present? Yes or no. So on to contraction patterns. A normal contraction pattern is 5 contractions or less in a 10-minute window, averaged over 30 minutes. Tachysystole is when there are greater than 5 contractions in 10 minutes, averaged over a 30-minute window. BRA is for the baseline rate. A normal baseline rate is 110 to 160. And again, you're probably only going to see those 1-teens in your babies that are large and that are like 39, 40, 41 weeks. Baseline rate should be documented in increments of 5 beats per minute. You really shouldn't put down a range for the baseline. Baseline rate excludes accels and excludes periods of marked variability. Bradycardia is less than 110, tachy is over 160, and baseline rate, you're really looking at this for at least a 10-minute window. So here we've got an example of a baseline bradycardia. Heart rate is around 100. And here's a baseline tachycardia with a heart rate of 165. All right, variability next. So variability is defined as fluctuations in baseline rate that are irregular in amplitude and frequency. These are controlled by the autonomic nervous system. So variability is good. We want to see moderate variability. And here's a key point to remember. The presence of moderate variability reflects an intact pathway from the cerebral cortex to the midbrain to the vagus nerve to the heart. And when you see moderate variability, that reliably tells you that the fetus is not acidotic right now, right at the time that you're looking at that monitor strip. So variability can be described as absent, mild, moderate, or marked. So here we have absent variability. The amplitude range is really undetectable. That looks pretty much straight across. There's not a beat-to-beat variability presence. Now there is a deceleration going on at the end of that. We can't really tell what type of deceleration because we can't really see the contraction, but it's got late features. We'll see more on that in a bit. Here is an example of minimal variability. So you see this little increases and decreases from beat to beat. The line looks more squiggly than the last one I showed you. And the amplitude range is very small. It's detectable, but it's less than 5 beats per minute. Moderate variability, and sorry, this isn't really the best strip here from also because it cuts off, but moderate variability is an amplitude range of 6 to 25 beats per minute. So here we see variability that looks like it's, roughly 10 beats or so apart. Here is marked variability. You can tell from the contraction strip on the bottom, it looks like she's pushing or in a lot of discomfort, one of the two. But you have an amplitude range in your variability of greater than 25 beats per minute. So if you think back to those a few slides ago to baseline rate, we cannot determine what the baseline is during a period of marked variability. Okay, more on variability. So causes for decreased variability to be aware of. You can see normal sleep cycles. So these usually last up to 20 or 30 minutes. You'll notice this in maybe a monitoring strip that has looked fine. You've had good moderate variability with accels. Then you get these periods of minimal variability where you see like a real decrease or just complete cessation of accelerations. This can be normal. Think of sleep cycles. Usually they won't stay in this for more than a half hour. If you've given any kind of sedation to mom, it's going to sedate the baby a bit too. So if you've given Nubane or Stadol for pain, think of what magnesium does to patients. Most of you have probably seen a patient on magnesium. Usually that makes moms lethargic. It kind of does the same thing to baby. Steroids, interestingly, can decrease variability in babies some as well. And then also bad things happening decrease variability, like an abnormal acid-base balance. You might see moderate variability go away and get minimal or absent if it's due to acidosis. Causes for marked variability can be very benign things. A really active fetus that's moving around a whole lot is going to have periods, sometimes prolonged periods of marked variability. However, bad things can cause marked variability too. Repetitive cord compression, hypoxia, certain medications can do it as well. So really key point on this slide, and I mentioned it once before, know this stuff down here about moderate variability. It reliably predicts the absence of metabolic acidemia at the time in which you observe it. That's the one one of the really safe statements you can make about fetal monitoring is that when you have moderate variability, it reliably predicts the absence of acidemia at the time you observe it. It doesn't tell you that things are going to be fine later on, but it tells you that right now the baby's not acidotic. Alrighty, so accels. So some definitions here. Think about writing these down so that you have them for later. So accelerations in a baby greater than 32 weeks gestation are defined as a rise in the heart rate of at least 15 beats per minute for at least 15 seconds. Preemie babies under 32 weeks have a little less stringent criteria. They only need to go up by 10 beats per minute for at least 10 seconds to be qualified as an acceleration. Now, accels are abrupt. The onset of the acceleration to the peak of the acceleration should take less than 30 seconds to get there. So if you see an example right here, there is the onset of the acceleration, and from here to here is only about less than 30 seconds before you get to the peak of the accel. Accels are good. Accels are reassuring that you've got a well-oxygenated fetus and a normal acid-base status. So when we're talking about reading a non-stress test, the presence of accels make the non-stress test reactive. A lack of accelerations, on the other hand, is not a specific finding. It doesn't necessarily mean there's something bad going on. Now, decelerations. We're going to spend the most time on this portion of the Dr. C Bravado mnemonic. Decelerations can be classified as early, variable, or late. So that's really the most important part of your classification scheme here is, are they early, variable, or late? Also, you do need to know the difference between recurrent, intermittent, and then periodic and episodic. So these are pretty simple definitions. You might want to write them down for later. So a decel is recurrent if it occurs with more than half of contractions. Decels are intermittent if they occur with less than half of contractions. Decels are periodic if they are associated with uterine contractions, and they're episodic if they are not associated with uterine contractions. So in a really stressed and acidotic fetus, you can see things like episodic late decelerations. They have the shape of a late decel, but they're not occurring in relationship to a contraction. They're occurring spontaneously. Those would be episodic. Most decels that you're going to see are going to be periodic. They're going to be associated with a uterine contraction. All right, so on to some examples. So early decels. An early decel is going to mirror the contraction. They are gradual. So keep in mind this gradual versus abrupt distinction. Early decels are gradual, meaning the onset to nadir takes at least 30 seconds. So here's our example. Here's contraction is starting, somewhere right around here. The decel is starting similar, right around here. The peak, the trough or the nadir of the deceleration matches the peak of the contraction. Once the contraction is all done, the heart rate is back to baseline right here. So the physiology is usually fetal head compression, stimulating vagal nerve output. Once the head is no longer compressed, the parasympathetic system is no longer firing, and you get back to baseline. Variable decelerations. Now, these differ from early decelerations in that their onset is abrupt. By abrupt, I mean the onset is less than 30 seconds from onset to nadir. There is a decrease in fetal heart rate by at least 15 beats per minute for at least 15 seconds. Now you'll notice in early decelerations, there was not a requirement for how far or for how long the heart rate needed to decrease. Variables, they need to go down by at least 15 beats for at least 15 seconds to be considered a variable decel. A variable decel needs to last less than 2 minutes. If it's greater than 2 minutes, then it is a prolonged deceleration. And variables are not necessarily associated with contractions, but by and large, they usually are. A question was raised during the presentation of, well, how would a variable deceleration occur outside of the context of a contraction? And variables typically occur from cord compression. So sudden fetal movement, if baby turns and now a different part of the baby, say, the shoulder is compressing the cord, you can have a variable decel from that as a result of fetal movement. So that would be the mechanism. So a little bit about the physiology of cord compression. So if you remember back to that slide that I showed you on fetal circulation, this is a bit of where that comes into play. So in a variable decel, think of a contraction starting and the cord being compressed. So the umbilical vein is going to be compressed first because the vein does not have smooth muscle around it to protect it from that compression. So when the vein is compressed, there is suddenly decreased blood flow to baby and a decrease in cardiac output. This is going to cause an increase in fetal heart rate, and a transient increase in heart rate is seen like as what's often termed as a shoulder on the deceleration, where you see this brief increase in heart rate before the variable decel, and you can see it at the end of the deceleration as well. Then, pretty quickly, after the vein is compressed, the umbilical artery is then compressed. Compression of the umbilical artery causes fetal hypertension, which leads to a baroreceptor response to stimulate the vagus nerve to slow the heart rate. Now you guys should remember baroreceptor responses happen fast, therefore variable decelerations are abrupt. So take a look at the decelerations in this really awesome, well-printed fetal heart rate monitoring strip that I've included for you. So does this look abrupt or gradual? Is it recurrent or intermittent? Is it episodic or is it periodic? So answers would be, it is abrupt. The onset to nadir is less than 30 seconds. In most cases, this is occurring from here to here. So that looks like a span of about only 10 to 15 seconds. They are recurrent. They're obviously present with more than half of the contractions. And then they are periodic, occurring in association with contractions rather than episodic, occurring whenever they want to. All right, on to late decelerations. So late decelerations are a visually apparent, gradual decrease in fetal heart rate with return to baseline. The onset to nadir is greater than 30 seconds. And the onset, nadir, and recovery occur after the beginning, peak, and ending of the contraction, respectively. And that's, of course, going to be when they are associated with contractions. You're going to see heart rate humming along at baseline into the beginning of the contraction, maybe even the middle of it. Then it starts to drop off, and then the heart rate doesn't recover till baseline until after the contraction has concluded. The physiology here is uteroplacental insufficiency causing fetal hypoxemia, causing myocardial depression. This is a chemoreceptor response. The chemoreceptors perceive a decrease in oxygenation. This leads to an increase in alpha adrenergic output by the fetus, which causes fetal hypertension, and then a baroreceptor response to decrease the heart rate. It's a multi-step process. It takes longer than a variable deceleration to slow the heart rate. So here are some examples of late decelerations. So you see the onset of the contraction right about here in the heart rate, and we're still at baseline. Peak of the contraction, we're still at baseline. And then late during the contraction, we start to drop off. We drop off very gradually. That's a slight slope. And then the contraction is done right around here. Done right around here. We're not back up till baseline until we're here. Now we've got another contraction next, and again, a slight deceleration after. So key thing to look at here is these decelerations, they can be subtle. There is not a requirement for how far the deceleration needs to drop by. variable decelerations need to drop by at least 15 beats per minute. Late decelerations can be a real subtle drop-off, only 4 or 5 beats per minute. So they can be kind of hard to pick up. Oftentimes you've got to look at a longer period of a heart rate strip to catch these. Remember also, you want to classify them as recurrent or intermittent. The ones shown here are recurrent. You've got 3 contractions and you've got 3 late decelerations. So the mechanism again is uteroplacental insufficiency causing a chemoreceptor response. It's a multi-step process. It takes a little while for these to show up. Last in our mnemonic is your overall assessment. So your NICHD classification system. You're going to lump these into category 1, 2, or 3 rather than saying, yeah, the heart tones look good, or they look reassuring, or they look bad, or they look non-reassuring. So category 1 and 3 have really strict requirements for what goes into those categories. And then category 2 is everything else. All right. So category 1, you see a category 1 strip, you're happy. You know that the baby has a normal fetal acid base status. So a category 1 strip is predictive that the fetal acid base status is normal at the time you are viewing it. To be included in category 1, it must, no, this is a must, have all of the following characteristics. You got to have a normal baseline, so 110 to 160. You got to have moderate baseline variability. You have to have an absence of late or variable decels. So a single variable decel on that 10-minute window, you don't have a category 1 strip. Okay? Early decels are okay. Early decels are not necessarily a bad thing. They're from head compression and parasympathetic nervous system output. So early decelerations are the one type of decel that can be present on a category 1 strip. Now another little key thing here, accels don't need to be present. Certainly if we see them, they're good. Accels need to be present to call a non-stress test reactive, but accels don't need to be present to have a category 1 fetal heart rate monitoring strip. Your key here is the presence of moderate variability and the absence of late or variable decels. A category 2 strip. Key point here, a category 2 strip is not predictive of fetal acid base status. And this is really like a garbage can term that we throw everything that's not a category 1 or a category 3 tracing into. So a category 2 tracing can have all kinds of different bad things showing up on it. You can have tachycardia. You can have recurrent variable decels. You can have recurrent late decels. You can have prolonged decelerations. You can have accels. You don't need to have accels. You can have bradycardia. So a lot of bad things can go into one. And there are different degrees of category 2 strips. You're currently going to see some category 2 strips where you're not that concerned about it, and others that look really nasty and you have to act on. Some hospitals have subdivided category 2 into category 2A, B, and C. However, I wouldn't really get into that in this lecture, and we don't do it at our hospital because the bottom line, even if you subdivide it that way, a category 2 strip is not predictive of fetal acid base status. What category 2 strips do require is further evaluation or intervention. You need to have a plan for how are you going to tell that the baby's acid base status is okay. So that evaluation might be as simple as continuing to monitor. Well, it looked okay before. Now I've got some variables. I'm going to watch it for 10 or 15 more minutes and then decide. So oftentimes you're going to have to do something a little bit more than that, and we'll get into possible interventions a little bit later on. All right, then category 3 tracings, these are abnormal. A category 3 tracing is predictive of an abnormal fetal acid base status. These are the kind of things that make us kind of panic on the labor and delivery floor. And you have to include, it's got really strict requirements for what makes a category 3 tracing. It has to have absent variability plus one other bad thing. So absent variability plus recurrent lates, recurrent variables, or bradycardia. So if you have just absent variability, that's still category 2. If you have minimal variability and recurrent late decels, that's still category 2. The other thing that can be a category 3 tracing is a sinusoidal pattern. There's an example of a sinusoidal pattern right here. All right, then here's just a summary slide of your 3-tiered system. What falls into category 1, what falls into category 3. 1 is normal acid-base status at the time. 3 is abnormal acid-base status. You got a category 3 strip. You need to expedite delivery. And then category 2 is everything in between. So management. Here is another mnemonic for you to write down. This is helps you remember your management options for what to do with a category 2 and 3 fetal heart rate tracing. So the mnemonic here to remember is poison. P is position change. O, oxytocin off. So if you got a tachysystolic environment, think of turning off the oxytocin. I is IV fluid bolus. S, sterile vaginal exam. C, is the situation changing? Is there suddenly a cord being compressed? Is there suddenly a change in fetal station? O is for oxygen. N is to notify your backup. So the goals of poison is to maximize blood flow to the uterus, maximize oxygenation to the uterus. So think about giving IV fluids oxygen that does that. Think about moving, changing position, maybe getting baby off of a cord, and then assessing and improving the uterine environment when you can. All right, so next up, we're going to do some practice tracings to help you tie all this together. So have your Dr. C Bravado and your poison mnemonics handy. All right, case number 1. G3P2002 at 39 weeks presents in spontaneous labor. She's had an uncomplicated pregnancy to this point, had spontaneous rupture of membranes 1 hour ago for clear fluid. She's 5 centimeters dilated, 90% effaced, -1 station, and has received no medications up to this point. So take 1 minute and kind of run through your Dr. C Bravado mnemonic for this tracing. This is the part of the presentation that, of course, works a lot better in a large group than it does watching this individually, so bear with me. All right, so DR, determine risk. This is a 39-week uncomplicated pregnancy, spontaneous labor. So this is about as low risk of a situation as you're going to find. Contraction pattern. What you want to do is look at how many contractions are in a 10-minute window. So here you can count 1, 2, 3, 4 contractions in a 10-minute window. So do you have a normal contraction pattern or do you have tachysystole? Since you have less than 5 contractions in a 10-minute window, this is a normal contraction pattern. Baseline rate is next. I know this can be a little bit tricky to see, but you've got 120 right here at this line, 150 at this level. So your baseline rate here, I would call this probably 130s. Your segments to look at are your areas in between accels. So this is a good segment here for determining baseline. This is a good segment here for determining baseline rate. Variability, I think this is an easy one. Your variability is moderate. Accels, you do have accels present. These guys right here and right here, there's an abrupt increase of at least 15 beats per minute, lasting at least 15 seconds. Next is D cells. You do not have any decelerations present. So your overall assessment for this, hopefully you determine that this is a category 1 fetal monitoring tracing. On to the next one. We'll complicate things just a little. You've got a G2P1 at 41 weeks and 3 days. This is a post-dates induction. Your patient has received misoprostol overnight and is now on Pitocin, dilated to 4 centimeters, 75% effaced, and -2 station. Uncomplicated pregnancy, aside from being a little bit post-dates. So run through Dr. C Bravado. First thing to do, determine risk. Still relatively low risk, but certainly a little bit of a higher risk situation than our last patient. So I'd kind of call this a medium risk situation due to maternal risk factors. So she's post-dates, you got a greater chance of there being meconium in the fluid, greater chance of oligohydramnios being present, and then intrapartum factors, things we're doing to her. We're medicating her. This is not a natural labor. We're giving Pitocin. Contraction pattern, it looks like we have 1, 2, 3, 4, 5 contractions present within a 10-minute window. So you have a normal contraction pattern. Your baseline rate, so you need to look outside of the accelerations. So roughly from here to here, you've got baseline. Here to here is probably a little bit of a better baseline assessment. So I'd probably call that baseline rate of about 110. And it's probably our closest area to round it off to the nearest 5, baseline rate of 110. So that's normal. And we got a 41 weeker, so we're more likely to have a lower baseline. Variability, hopefully you characterize the variability as moderate in this tracing again. Accels, you do have accels present, one right here, and a couple more throughout this. Decels, it again appears that decelerations are absent. So your overall assessment, this is again going to be a category 1 tracing. Category 1 tracing means baby is not acidotic at this point in time. All right, part 2, same patient, G2P1, 41 weeks, post-date induction. You just gave her Nubane. So what happened here? Determine risk, maybe a little higher. We did more stuff to the patient. Contractions, looks like we still have a normal uterine environment. We haven't gone into tachysystole, but our baseline rate has changed. Baseline rate now looks like it's down to 100. All right. Variability is still moderate. Accels now appear to be absent. Decels, looks like we have a decel over here. Now, I think I would characterize this as an early deceleration because once the contraction is done here, we're back to baseline. All right, and the peak of the nadir of the deceleration matches the peak of the contraction fairly well. Remember, early decels don't have a number requirement for how deep they need to be. So, how would you characterize this? What's your overall assessment? I would call this a category 2 fetal monitoring strip. I wouldn't be all that worried about it if I knew what caused it, the Nubane, and if I knew it happened right after a normal strip. But if it kept on like this, I would certainly want to do something about this to maximize oxygen delivery to the mom or do something to better reassure myself. So options for how to reassure yourself: if her water's broken, you can provide fetal scalp stimulation and see if you get an acceleration. That's going to make you more reassured about fetal acid base status. And then you need to monitor for longer here as well. All right, case 3, new patient. You've got a G1 P0 at 38 weeks in spontaneous labor, dilated to 9, 100% effaced, and +1 station, uncomplicated pregnancy. So take a minute to do your Dr. C bravado for this tracing. All right, so determining risk, we've got a spontaneous labor of a near full-term patient, so pretty low risk. Contraction pattern. Now, how many contractions do we have here? 1, 2, 3, 4, 5, 6 contractions. So technically, this is tachysystole. If this is normal labor, you're probably not going to do much about that uterine environment as long as you're approaching delivery, which it looks like we are at 9, 100, and +1. Baseline rate here, this might be hard for you to read, but this is 120 and this is 150. So I'd probably call our baseline rate right about 150. Best place to view it, right here. Do we have variability? Yeah, we do, but not very much. It looks like an amplitude of less than 5 beats per minute, so I'd call it minimal variability. Do we have accels? No. Do we have decels? Yes. So what type of decelerations are present? You get a bit of a clue from the history. dilated to 9 centimeters and +1 station. So you're thinking there is some pressure being placed on baby's head. So let's take a look at this deceleration right here. The nadir of the decel matches the peak of the contraction. When this contraction is done right here, we're back to that baseline rate of 150. This one over here looks about the same. I would call these early decelerations. Overall assessment, this is a category 2 tracing. So think about your poison intervention and things that you would do for this. You've got some options. This is a category 2 tracing wherein if the strip looked fine and now we're pushing, I'd probably carry along with pushing. I might do some scalp stimulation to see if I can get an accel. That would provide me some reassurance. If I don't get that, or if this tracing continues to appear this way, I'd probably have mom change positions and see if we can improve the heart rate there. If that doesn't work, think about promoting more oxygenation to baby by giving IV fluids or giving oxygen. And if she's not making good progress and the heart rate continues to get worse, you might need to think about changing the uterine environment because you've got tachysystole, so changing the uterine environment by giving a tocolytic like terbutaline. All right, next case, case 4. You have a G1P0 at 39 weeks in active labor. She's got a history of diet-controlled GDM and is undergoing a Pitocin induction. Cervix is 6 centimeters dilated, 100% effaced. She's ruptured for clear amniotic fluid. So determine risk and go on from there through your Dr. C. Bravado mnemonic. So risk, you've got, again, kind of a medium risk situation here. Contractions, you've got 4 contractions in a 10-minute window. So in normal uterine environment, you do not have tachysystole present. Your baseline rate, looks like back here you were 140 or 145. By the end of this, I'd call this a baseline rate of 150. Variability looks okay. It looks moderate. Accels are not present. Decels are present. And take a look at the decelerations. These are abrupt. You have onset to nadir of less than 30 seconds. It's a sharp decrease. So this is a variable deceleration. So your overall, are these decels recurrent or intermittent? I'd call them recurrent. You've got 4 contractions, 3 decels, so that's over 50% of your contractions are associated with a decel. And as for episodic or periodic, I would call these periodic because they appear to be associated with contractions. So look at your poison mnemonic. What are your management options for this? Variable decels, I think first about repositioning, and then I think about other ways of maximizing oxygen flow to baby. So IV fluid bolusing, oxygen. If you have prolonged or recurrent decelerations that you cannot resolve with those measures, and you've got a ruptured patient, think about an amnio infusion to put some more fluid around the baby and provide a little bit more cushioning to the umbilical cord. All right, case number 4, same patient, this continues. So another half hour goes by and this happens. Think through your Dr. C. Bravado, think about what you have now. So same risk patient, so kind of moderate risk. You know what the pattern looked like before. These are both category 2 strips, but I think you can kind of subjectively say that, this one looks a little bit worse. My variable decels are getting longer and they're getting deeper. So now what do you want to do? Reposition the patient again. Maybe get in a knees chest position. This might be where you think about an amnio infusion if you're still 6 centimeters dilated. When I see a change like this, I would certainly also do a vaginal exam, see if there's been a change in position. Maybe the station is lower, maybe you're further dilated. All right, think about using all of your maternal intrauterine resuscitation measures when you start to see a pattern like this. So position change, give oxygen. You may need to you may need to change the uterine environment. So if you're giving Pitocin, I would shut it off for sure for a strip that looked like this. All right, things go on from there. Now what do you do? So you've degraded into a prolonged deceleration. So if this over here on the far right continues, and this goes on for more than 2 minutes, now you've got fetal bradycardia. So right now, this is still a category 2 strip, but it's a really, really ugly one. And it looks like if things go on, this might degrade into a category 3 strip. So you've got to act fast here. This is where you really need to expedite delivery and maximize all of your intrauterine resuscitative measures. Definitely be calling your obstetric backup when you see something like this. All right, next patient, case 5. This is a 41-year-old, gravida 3, para 0 at 37 weeks. She's being induced with misoprostol for chronic hypertension. This is 4 hours after her first dose of misoprostol. Nurse calls you to take a look at the strip and inquire as to whether or not you can give another dose of misoprostol. So run through Dr. C bravado and think about what you would want to do. Would you give another dose of misoprostol or not? So determining risk, we've got a patient who is 41, who has chronic hypertension, who's being given misoprostol. So we got a couple of reasons to think that there might be some higher risk for uteroplacental insufficiency from chronic hypertension and advanced maternal age. Our intrapartum risk factors are we are inducing with misoprostol. Contraction pattern, that actually looks okay. You've got 4 contractions in less than 10 minutes, so that's normal. It's not tachysystolic. Baseline rate, this is a really tricky one to read. This is 120, this is 150, so I'd probably call the baseline rate around 140. Variability is decent, I'd call it moderate. Accels, you have no accels. Decels, now you do have decels. As for what type of decels these are, I hope you pick up that these are late decelerations. So the contraction occurs, and while the contraction starts, we're still at baseline. Once the decel starts, we're past the peak of the contraction, and once we're back to baseline, oops, sorry, that's way too squiggly, but once we're back to baseline, the uterus is at resting tone. So that is a late deceleration. So this is a chemoreceptor response from uteroplacental insufficiency, a slowed response. And remember, late decels, they don't have a number requirement for how far the rate needs to drop. It can be subtle. Here we're seeing it only drop by 10 beats per minute or so and have a prolonged recovery. So you would categorize this as a category 2 strip. You've got moderate variability, but you have recurrent late decels. You really see them with all 4 contractions. So hopefully you're not going to give that next dose of misoprostol. You're going to think about repositioning the patient, giving oxygen, and seeing if this heart rate pattern can clear up and improve. So we'll conclude with a number of slides on the basics of antepartum surveillance. And then once that's finished, I think I've got about 9 or 10 review questions for you guys just to help lock all this down. So antepartum surveillance. These are basically tests of fetal well-being that are available to you to use. So number of different options here to be familiar with. You have some of the very basic, kick counts or maternal fetal movement assessment, to non-stress tests, biophysicals, contraction stress tests, and then we'll talk briefly about umbilical artery velocimetry. So first, maternal fetal movement assessments or kick counts. This is something that I do make sure I talk about with all of my patients once we're getting into like the mid-3rd trimester. Women should have a good idea of how active their baby is on a day-to-day basis. And I tell my patients that if you feel a real substantial decrease in your baby's movement or feel like you're just not feeling him or her move as much as you feel they should, give us a call, let us know. That's something we need to talk about. So there's not really a standardized duration or number of kicks or movements you should feel to do a kick count, but there's a few different methods out there. Probably the most common one is, 10 movements in 2 hours is what you should feel. Sometimes, 4 or 5 movements in an hour. I've seen those recommended. So what I tell patients to do to monitor fetal movement, if I'm concerned about it and if they're concerned about it, is to stop what you're doing, sit and relax, hydrate, drink a glass of water, and see if you're just focusing in on fetal movements, do you feel a minimum 10 movements in 2 hours? All right. Or if you've just got an hour, do you feel at least 5 movements in 1 hour? So that's just a good kind of self-check of fetal movement that you can consider doing with your patients. But the basic kind of bottom line principle here is most moms are going to have a sense of how much their baby is moving, and if it's a real drop off in movement and activity, I want to know about it. All right, more technical stuff. The non-stress test. So frequently we're ordering these for our patients, once beyond 32 or 36 weeks, depending on the condition. Purpose of bringing it up here is not to go over all of the conditions for antepartum fetal surveillance and not to go over how often to do them. I just want you guys to have the basics on interpretation and the basics on why we do these tests. So the principles of a non-stress test is that a fetus who's healthy and non-acidotic will temporarily accelerate the heart rate with movement. So you should see an accel, meaning an increase from baseline of at least 15 beats per minute for at least 15 seconds. You should see an accel, and then you have a reactive strip if that's present. All right. A non-stress test should take 20 minutes. If you do not have a reactive test, meaning the presence of at least one acceleration, if you do not have that within 20 minutes, it can be extended to 40. It's considered to be a non-reactive, non-stress test if there are no accels over 40 minutes. If you're non-reactive at 40 minutes, you need to move on to another method of assessing whether or not you have a healthy fetus, a non-acidotic fetus. Variable decelerations are present, in up to half of these, but I don't want to go into all the specifics on what to do with that here. I think that's beyond the scope of this talk. So, good point to remember about non-stress tests and why we do them is that a reactive NST has a negative predictive value for stillbirth occurring within a week of 99.8%. So a reactive NST is very reassuring that a stillbirth is not going to occur over the next week. All right, contraction stress test. You're not going to use this that frequently, but I do want you to know the basics of it. So this is one of the methods used to investigate non-reactivity in an NST. Your basic options after a non-reactive NST are to do a biophysical profile or a contraction stress test. All right. So the premise of a contraction stress test is that oxygenation to the fetus is going to be transiently worsened by uterine contractions. So if the fetus is truly stressed and at risk of acidosis, the fetus is going to develop late and or variable decelerations once you add some stress to that uterine environment. So to successfully do a contraction stress test, you need to give oxytocin enough to produce at least 3 contractions of greater than 40 seconds in a 10-minute period. A negative contraction stress test, is meeting that requirement for adequate contractions with no late or significant variable decels. A positive contraction stress test is the presence of late decels after greater than 50% of contractions. So the presence of recurrent late decelerations is a positive contraction stress test. A stress test that is considered equivocal suspicious is one with intermittent late decels or presence of intermittent variable decels. An equivocal stress test is decels in the presence of contractions that are more frequent than every 2 minutes or lasting longer than 90 seconds. All right, so this gets pretty specific here, but if you have prolonged contractions or very frequent contractions and you have decels present, that's considered an equivocal stress test. An unsatisfactory stress test is less than 3 contractions in 10 minutes or an untraceable heart rate tracing. So if you're unsatisfactory, you may need to give more Pitocin to get to that 3 contractions, adjust monitors to see the heart rate well. I don't think that you're going to be tested on all of the specifics of contraction stress test scoring. It should really be adequate to know really the basic principles of it, that this is another way that you can follow up a non-reactive NST, see how the fetus does with the stress of contractions. This is always something you can then refer back to in real life. All right, what we're more commonly doing to follow up a non-reactive NST or to monitor antepartum is a biophysical profile. So a biophysical profile can be scored in 2 ways, out of 8 or out of 10. A full biophysical, which would be scored out of 10, is a non-stress test plus 4 separate ultrasound observations. All right. So an NST can be omitted if all 4 of the observations are normal. What you're observing for is fetal breathing, fetal movement, fetal tone, and amniotic fluid index. And in the infinite wisdom of whoever came up with the biophysical profile, this is 2 points for each. They get 0 or 2, so it's scored out of 8. Honestly, I don't know why it's not scored out of 4, but that's just the method that was chosen, is to score it out of 8. So for fetal breathing, you need to see at least 1 episode of breathing movements lasting over 30 seconds within a 30-minute period. For movement, there need to be at least 3 discrete body or limb movements within a 30-minute period. Tone looks at that movement and needs to see extension of an extremity with return to flexion or the presence of an opening or closing of a hand. Then an amniotic fluid index. The primary method for measurement of this is a single deepest vertical pocket of over 2 centimeters. You'll often see the amniotic fluid index being used, which is a composite measurement of pockets without cord, and that should be a minimum of 5. Scoring a BPP, like I said, 2 points for each component. A composite score of 8 out of 8 or 10 out of 10 is normal. A composite score of 6 out of 8 on the imaging is equivocal. 4 or less is abnormal. So when you send a patient for a biophysical profile and they go to fetal imaging for it, which is where we do the scheduled ones, these are being scored out of 8. They're doing the ultrasound components. So if your patient gets a score out of 6, they go to triage for a non-stress test. If their non-stress test there is normal, then their score is 8 out of 10. So that is okay. That is normal. If their NST is then non-reactive, 6 out of 10, that requires further monitoring. If they have a score of 4 on their biophysical, they need an NST. You're not going to end up sending them home if their NST is normal. They need prolonged monitoring. If oligohydramnios is present, that requires further evaluation regarding the remainder of the rest of the score. So if you see breathing, tone, movement, those are all fine, but you have oligohydramnios, you have a single deepest vertical pocket less than 2 centimeters, that baby requires observation. Generally, we're going to keep that patient in the hospital. All right. Modified biophysical profile is another tool to be familiar with. This is simply a non-stress test plus an amniotic fluid index. The overwhelming majority of the value of the biophysical profile can be obtained from these 2 measurements. So biophysical profile has an even stronger negative predictive value for stillbirth than an NST. The likelihood of a stillbirth within 1 week of a normal biophysical profile is less than 0.1%. So the negative predictive value is greater than 99.9%. And our last tool we'll talk about is umbilical artery Doppler velocimetry. So this is really just useful in the growth restricted fetus. there's no good data that it provides useful information about fetal well-being in the setting of normal fetal growth. This is measured in systolic to diastolic ratio. So the principle here is that you should have easy flow through the umbilical artery in diastole. The placenta should be a low resistance environment. As placental insufficiency increases, as resistance to blood flow increases, umbilical artery diastolic flow reduces. The velocity is going to reduce. So abnormal waveforms, decreasing velocity in diastole correlates with loss of functioning small arteries and capillaries in the placental villi. It progresses from reduced diastolic flow to absent and then reversed. If diastolic flow is absent or reversed, that's highly predictive of acidemia in a growth-restricted fetus. All right, that gets us through all of the didactic portion. What I have left is, I think, about 10 multiple choice questions for us to go through together, and then we'll be all set. All right, so review question 1. Take a look at this and decide what type of decelerations are these. Are they early, late, variable, or hopefully you don't pick option D. So you guys should get that this is B, variable decelerations. Reason here is these are abrupt in onset, so they go from peak to nadir in less than 30 seconds. And you see that's really your main criteria there. They mirror the contraction pretty well. You see some other characteristic findings that there are some shoulders to the deceleration, like here and here. You tend to see that as the umbilical vein is compressed first, and then pressure from the vein comes off last, so you get a little bit of a brief period of hypotension and increase in heart rate at each end of the deceleration. All right, question 2, what fetal heart rate tracing is this? Is this a category 1, 2, or 3? So you should be able to identify that it's not a 1 right off the bat due to the presence of variable decels. If you recall, the only type of decels you can have in a category 1 tracing are early decels. This is not a category 3 tracing because you do have moderate variability present. So you do not meet the strict inclusion criteria for category 1 or 3. This leaves you with a category 2 tracing, so option B. All right, next question. When fetal baroreceptors are stimulated by rising blood pressure, the fetal heart rate will do what? Answer here is fetal heart rate will decrease in response to baroreceptors. This is an abrupt response, like the response we see in variable decelerations. Question 4. Tachysystole is defined as what? Answer here is B, more than 5 contractions in 10 minutes in a 30-minute window. So some of you guys might have given consideration to option D. Yes, more than 5 contractions, but this is not correct because we do not specify the time period. If recurrent decelerations are present, if that patient is on Pitocin, you're going to want to stop Pitocin as part of your intervention for that patient. Question 5. Initial changes in a fetal heart rate pattern that may indicate worsening placental insufficiency and hypoxia include what? Is it early decels and a stable baseline, fetal tachycardia, deepening of decels with the rising baseline rate, fetal bradycardia, or recurrent variable decelerations? This might be kind of a tricky question because if you remember, category 2 tracings, which is what you're generally going to see and kind of what these options are depicting, are really not predictive of whether or not the fetus is acidotic. However, I did mention with deepening of decelerations or increasing frequency of decelerations, coupled with a rising baseline rate, that's concerning for hypoxia. So the answer is C. The pathophysiology going on here is continuous release of fetal catecholamines. You're going to see decelerations if there's uteroplacental insufficiency. This will typically be late decels. And with the increasing presence of catecholamines, that fetal baseline rate is going to gradually rise. All right, question 6. What type of decel is that? Is it early, variable, late, or not even a decel? Take a look. Answer here is A. This is an early deceleration. So what makes it an early is if you look at it, the onset, nadir, and recovery mirror the contraction. So when you are at the nadir of the deceleration, that's about right here, you're at roughly the peak of the contraction. You're right about here. And once the contraction is done right here, you're fully back to baseline here. If you remember, an early deceleration has no requirement for how deep it needs to be. In order to be a variable decel, it has to be abrupt, which this deceleration is not, and it has to go down by at least 15 beats per minute, which this deceleration does not. So answer here is A, an early decel. Question 6, what category heart rate tracing is this? All right, here you're going to have a category 1 tracing. You've got moderate variability. And remember, you are allowed to have early decels in a category 1 tracing. You can't have variables or lates, but if you have moderate variability, no variables, no lates, a normal baseline rate, you've got a category 1 tracing, and early decels are allowed. They are not a sign of fetal distress. They are a response to head compression. Question 7, what kind of decels are these? So take a look. Answer here is C. They are late and they are recurrent. So what makes them late is the onset, the nadir and the recovery come after the onset, nadir, and recovery of the contraction. So in our first example here, here's the nadir of the decel, contraction's already done. We don't get to recovery until after it's done. You have 3 decelerations with 3 contractions. It's over half the contractions. That makes it recurrent. Bonus question, is it episodic or periodic? These would be periodic because they are associated with the contractions. What category heart rate tracing is this? Would call this a category 2, but you are starting to get close to that category 3. I think you've got enough enough variability there to call this minimal variability. So if variability were absent and you had recurrent lates, you would have a category 3 tracing. Question 8. If an NST is non-reactive after 40 minutes in a term fetus, it should be followed by what? So B, answer here is a biophysical profile or a contraction stress test. You need another method of reassuring yourself that baby is in okay shape here, that baby is not acidotic. So you don't want to discharge home with instructions on monitoring fetal kit counts. You've done a more sensitive test than fetal kit counts already, and really a more specific test as well, and it's non-reassuring. Repeat NST within 48 hours is not the correct option because you don't have that negative predictive value of for fetal demise when you have a non-reactive NST. You don't want to do a mesoprostol induction because right now you don't have evidence that baby is non-acidotic and is going to handle the stress of receiving mesoprostol. Now, I can see you potentially think, well, why is mesoprostol not okay and a contraction stress test is okay? The answer here is with oxytocin, you can quickly turn it off. With mesoprostol, once you insert mesoprostol, whether vaginally or oral, it's going to work for several hours. You can't just shut it off like you can with oxytocin. So B is the correct answer. Question 9. If a routine NST is reactive, but variable decelerations are present, the appropriate initial assessment would be what? I don't think I directly addressed this in my explanation. I more kind of alluded to it. So your next step here would be to obtain an AFI. So if you see variable decelerations on a routine NST, you need to be concerned about the presence of oligohydramnios and that the cord is being compressed. So an amniotic fluid index would be your next step. You're likely going to prolong monitoring for this NST also to make sure that you're getting good accels, make sure that the decels are not recurrent, make sure that they're not getting deeper over time. So obtain an amniotic fluid index. Scalp stimulation is not going to be your right answer in this setting. If your patient's just coming for an NST, they're not ruptured. You're not going to be reaching the fetal scalp. Question 10. A woman is admitted to labor at 39 weeks gestation and placed on a fetal monitor. The fetal heart rate is 145 beats per minute and the variability is moderate. There are no decels or accels. The best interpretation of these findings is what? B, there is no evidence of metabolic acidemia right now. So what I really described there is a category 1 tracing. What you can confidently say when you have a category 1 tracing is that there is no evidence of metabolic acidemia right now. That doesn't tell you that a normal fetus is going to be delivered 2, 3, or 4 hours from now. It is predictive that there's no presence of acidemia, so C is incorrect. And remember, you do not need to have accels for a category 1 tracing. Those are not required. All right, we finally made it to the end of this presentation. I apologize. I see that it took me an hour and 26 minutes and not the hour to hour and 15 that I had hoped for. So things to do now, next steps. Complete your exam. So it's in your mailbox or maybe you've already picked it up. Turn it back into me in my mailbox, or you can just drop it off in my desk in my office. I'm going to grade it and I'm going to give it back to you with corrections. There are some tricky questions on there, and I want to give you the rationale for why the answer is as such, so you can use this as a learning tool for the NCC test and for real life. If you're a PGY1 resident or an OB track resident, stay tuned for information on sign up for the actual NCC exam. This will be an exam that you have to sit for at a Prometric-like center. PGY2 and PGY3 non-OB track residents, once you've scored 80% or better on the paper exam, you have met your requirement. So remember to like my YouTube channel or subscribe to it or do whatever that millennial stuff is that's done with YouTube channels, and come back for all your fetal monitoring interpretation education needs. Again, thank you guys for your attention.